What's up, guys? We are in another episode, another Care Pods podcast, whatever you may call it. We have a special guest, Dr. Adam Wright, good friend of mine. Great ortho surgeon here in the Dallas Metroplex. Our story is kind of crazy. A couple years ago, I wanted to reach out to doctors and find a way to relate to them and create relationships. So we did an initial podcast and we sat down and got to know each other and found out we had a lot in common. Like, both love God, both love our wives, both are passionate about healthcare and elderly people, and both had kids, and we just had a lot of synergy. And we would consistently meet up every other month or so and just at La Madeleine, and we were like, man, this is a great relationship. We've become really good friends, and we work together as well. He does ortho surgeries on his patients, and we have the opportunity to take care of them on home health services post-op. And so this podcast is really broken into two different episodes, one specifically talking about what an ortho surgeon does and how he takes care of himself and how does he have good work-life balance, also just the process of surgery. And so we're actually going to take a couple snippets and we're going to go through him breaking down the actual surgery of a knee and of a hip, and so you all can see that, and it's just going to be fun. So hope you guys enjoy this podcast, this episode with Dr. Adam Wright.
Dude, always good to see you. It's good to catch up with you. So Dr. Wright's a good friend of mine, but he's an amazing orthopedic surgeon. One of the things we talked about when we first met was there's just not a lot of good education, like for families, for people who are interested in getting a joint replacement, people who are interested in like knee surgery or even like therapy or injections. And so we were like, let's just talk about like what does it look like for families to have some good education. And Dr. Wright is one, I'm biased, he's a good friend of mine, but I'm biased in terms of making sure that families get good education. And so we were like, let's just chat, and let's just talk about things. And so if you don't mind, just tell us a little bit about yourself in general, what got you into being a surgeon, and we can go from there.
Sure. I mean, I totally agree. I think the education is really important, and surgery's scary. Going to the doctor's scary. So if you can at least know part of the process and have some light on the subject before you show up, it makes it a little easier.
Yeah.
I'm an orthopedic surgeon, born and raised in Texas. I have 3 brothers, and one of my brothers had cerebral palsy. Because of that, everything that I saw helping my parents take care of him, I really got exposure to the medical field in good and bad ways as I was growing up. I saw how hard it is to be on the patient side of things, and I really loved the science. And I was always loved math and science and getting involved in all that, and medicine seemed like the perfect fit for me. And I had always wanted to be a doctor since I was a little kid. Somehow I actually got to see open heart surgery at age 10 in the OR.
Wow.
And from then
Wait, how'd that happen? Hold on.
bring your son to work day.
That's amazing.
Sort of. My best friend's dad was a perfusionist, so he's a PA that runs the heart-lung machine.
Oh, wow.
And he was allowed to bring his kids to actually be in scrubs in the operating room to observe what he does. Funny enough, me and his son are both doctors now.
That's so cool, because of exposure.
Oh yeah, absolutely.
Wow.
And so from age 10, I'd tell everybody I want to be a cardiothoracic surgeon.
They looked at you like, whoa, okay,
Yeah.
okay, you will be that.
Right. And I changed to orthopedics instead for various reasons, but I loved surgery from the beginning because just the chance to change somebody's life immediately and take a problem that can't be fixed, and then you can fix it. And then you get to see great anatomy, you get to learn a skill that almost nobody has, and you really help people through a process. It was what I wanted to do. I knew from the beginning.
Wow.
In college, I thought about orthopedics maybe instead of cardiothoracics, simply because I really liked the orthopedic guys, Everybody wants to be Turk from Scrubs. And then also, the patients are really cool.
Yeah.
They're all motivated. They want to get back to doing the things they like to do. A lot of them are athletes, and so I just really got along with those type of people. Cardiothoracic patients are a little sicker, it's a little harder, and it can be sad. It can be hard. So I just naturally gravitated towards that, and that's kind of where I wound up.
That's crazy. So now, like, you look back, if you look back on like that path, and you were to say, okay, like someone who's considering like either going this route or this route, like what would you recommend for that person? Like, someone who's going into school. Right?
First thing I'd say is have an open mind. I mean, it was a very hard decision for me, even thinking I was pretty sure I wanted to do ortho all through medical school. I loved ENT, I thought about emergency medicine, I loved acute care trauma surgery. And there's so many ways, if your goal is to help somebody, to accomplish that goal.
Yeah.
And you might be surprised what you like.
Yeah.
Now, certainly there are things that you will realize match your personality better, or even just the people around you in that field. It just feels like home. And it just felt like home.
Was there any, like, you know, one of the things we were talking about right before was kind of really breaking down, you know, specifically people who are interested in becoming an orthopedic surgeon or becoming a doctor, right? I know a lot of times, you know, like the title doctor can kind of weigh on people. Did you ever experience that when, like, you were going in, you wanted to do cardiothoracic surgeon, then ortho? Did it bother you that that you switched, right? How did you deal with that? Just curious.
You mean like instead of being a surgeon rather than a doctor?
Yeah.
Well, I think just like anything, you take pride in your identity.
Yeah.
And when you know that this is what you do and this is your skill set, you know, then that really becomes a part of you, and you get excited to claim that.
Yeah.
And excited to learn that.
Yeah.
And when you start off and you start residency, it doesn't matter what you're going to residency for, you feel like a fraud because you don't know anything yet. You know, and you get to introduce yourself as the orthopedic surgery resident. You know, in the beginning, you definitely emphasize the resident because you're like, I don't know anything.
Yeah.
You know, and you really realize very quickly how much you don't know. And if you were a real learner, you keep that attitude your whole life, and you keep that humility, so you keep learning. But towards the end of residency, you realize, hey, I actually do know what I'm talking about. I've learned this, I've seen this before, which is a great feeling.
And that builds confidence. So it's like basically saying, hey, be confident in who you are as a person, and then kind of go from there.
Right.
Yeah, that's cool. So what led you to actually be an orthopedic surgeon? Or would you say, like, particularly joint replacements, what, like, caught your eye when you were thinking about being a surgeon?
So there are, I mean, at this point, I think probably 10 subspecialties within orthopedics.
Oh, wow. Okay.
And most people think orthopedics is just feet, you know, that's one of them, foot and ankle for sure. You know, but, you know, trauma, tumor, sports, shoulder and elbow is one, joint replacement, hip preservation, pediatrics.
Yeah.
There's so much within one field. I loved joint replacement for several reasons. The patients are great. You know, they love their families, they love hanging out, doing fun things. They want to get back to it. They were usually good at something before, and just time and arthritis has taken them out of the game, and they want to get back. And so that is a very fun group of people to work with. Also, it's usually older patients. Now, not as much as it used to be. We're expanding our indications, and people are getting arthritis younger and younger. But I think old people are great.
Yeah. I like them.
I love them. They have perspective on life. People our age, I think, are the worst sometimes because we don't have any perspective on life, and the pain is the worst you've ever felt. And
Lack of wisdom, too.
Yeah. People who have had arthritis for 20 years, they know what real pain is. And when they tell you something hurts, you believe them because they've been through it. And I think they're just happy people, you know, people that have been around the block, they have wisdom, and they're great. They usually listen to what you tell them. They want to get better, and they want to be good patients.
That's cool. That's a good point. Did you ever get the opportunity to, in residency, I guess, shadow joint replacements and do that? Is that kind of what led you to that as well?
Oh, yeah, it's a mandatory rotation.
Yeah,
you know, you can't go call yourself an orthopedic surgeon and not how to do a hip replacement.
Yeah,
because you're taking call typically as you're getting started in your career. People fall and break hips. It's one of the most common orthopedic injuries that's out there, and you have to know how to manage that.
Wow.
So it's required to do a certain amount of these cases as you graduate residency to even be certified. However, once you get into practice, I think the average orthopedic surgeon does 8 hip replacements in a year, which is not a lot. I mean, I may do that in a week. But that's because that's what I do. But you have to get the experience in joint replacement to graduate residency.
What was it like going into your first joint replacement? Do you remember?
I remember. So my first surgery rotation, even as a medical student, I'd got an elective in orthopedics, and my first case, they taught me how to scrub in right before I went into the surgery, was a hip replacement. And the residents were kind of playing some pranks on me since I was the new guy, you know. And one of the things when you do joint replacement surgery is you crank your hood down, and we wear these surgical hoods. And they told me that you need to make sure and crank this thing down as hard as you possibly can, because you don't want it falling off in surgery. You're going to get kicked out, get fired or whatever. So I did. I mean, I did exactly what they told me to do. And then, you got an ear-splitting headache about 20 minutes into surgery.
Man.
Now, fortunately, you could adjust it, but it was the resident that was doing the surgery was terrible at it. It took 5 hours, and I thought, well, I don't know what I want to do in orthopedic, but it's definitely not joint replacement.
Wow.
Then I realized it's actually awesome, if
yeah.
you know what you're doing.
Yeah.
And so over time, I realized, no, this is the best part of orthopedics, I think.
Wow, that's cool. Wow, that's crazy. So what are some of like the most common joint like conditions and injuries that you encounter, like just in general?
I see a lot of hips and knees,
Okay.
and with knees, there's several things that'll happen for a lot of people. Meniscus tears and arthritis are kind of the main things that we see. That's usually just dependent on if it's a meniscus tear or arthritis, and very often people have both. Sports injuries or things that just kind of gradually get worse over time. On the hip side of things, arthritis is a very common thing that I see. Fractures are common.
Okay.
Not as much in clinic. That's more in the ER, but I do have people even show up in clinic with a broken hip that fell this morning and just got in to see us. And then bursitis, muscle tendon tears. We see all of those sort of things pretty regularly.
What's the bursitis, if someone didn't know that? What is that?
Bursitis, tendonitis is one of the most common things I see around the hip. People typically complain of pain on the side of their hip. It's worse when they're sleeping on that side. Hurts going from sitting to standing or transitional movements. Hurts going up and down stairs. And it's usually isolated to one spot. People don't even really realize how painful this is until you kind of poke on the area and they jump off the table and you say, oh yeah, that's the spot. That's where it hurts. It's very treatable too, which is one of the great things about seeing it. Anti-inflammatories, physical therapy, injections usually takes care of it. It's not something that you typically need a surgery for. That's good news. Whenever you go to the surgeon, they can tell you don't have to have surgery. That's a good day.
Yeah, because it's like the last thing in the world is like, oh, I just got the hip.
Right.
My hip is hurting, and then now I got to go into surgery.
Right.
That's crazy. Wow, that's cool. What are some things that you've seen just in general with your experience in a patient's having like bursitis or having constant arthritis? What are some of the things in terms of treatments that are non-surgical that are like really common for patients to consider? So
very often I'll tell someone they have arthritis of the hip or the knee, and it's not unusual for them to cry actually sometimes. And then a lot of other people, they know it's coming. They're not surprised that they have diagnosed it themselves. So the reaction can be all across the board. And if they're worried and if they're nervous, I can tell them there's a lot of things we can do. This is a very treatable condition. And of course, the nuclear option is surgery, but sometimes it's a good option.
Yeah.
But before then, there's all sorts of things that help. So there's things like I call the easy stuff. They may or may not be easy. Weight loss, right? It's not easy. It's easy to say, but not easy to do, especially when your joints hurt. Physical therapy, that's very good. It keeps the muscles strong. It keeps you moving, which helps the joint function better. Anti-inflammatories, a great option for most people, but those medicines aren't great for your stomach or your kidneys, and they can interfere with blood pressure medicines, blood thinners, and there's lots of reasons why maybe you shouldn't take them long term. Injections, lots of different flavors of those. Braces, depending on the joint. There's a lot of things that we can do short of cutting somebody open. But if those things fail,
that's when
we have a great option too.
That's good. Wow. So now let's talk about someone that's needing surgery. Like, say for instance you've done everything they need to do, like gone through the easy stuff, right?
Right.
What they walk into your office and now it's like, hey, we got to get ready for surgery. What are some of the things, the most common questions that you may hear from families, like, or a patient? They say, all right, I'm going into surgery. Like, what are some of the questions they ask you right off the bat?
I think the most common question I get is, how long is the surgery going to last? Which always makes me laugh inside, because you're going to be asleep. Like, what else are you doing that day? It just makes me laugh, because I mean, I tell patients you're not going to remember half the day.
They're like, they're open.
So
they're done.
you're going to exactly. And very often I'll tell people, well, this is the last thing you're going to remember, because the anesthesiologist is going to come in next and give you the good drugs. But usually the surgery itself, I tell people it's about an hour. Now they'll be in the room for about 2 hours, typically to to get you positioned. That takes some time to put you off to sleep. What people don't know, when you're asleep in your bed, you're kind of rolling around, you're moving. When you're anesthetically asleep, you're out. You don't move at all. So we make sure and pad you. You know, you don't want your elbow resting on something or have a crick in your neck when you wake up. So that takes some time to make sure people are well padded. And then we clean off the leg. There's usually several different types of scrubs that we do. Then we do the surgery. It takes about an hour. But then we wake you up and make sure you get transferred over to the stretcher that you came in on. And so all in all, room time is about 2 hours.
Wow.
But it's very important to be quick and efficient with the surgery. You don't want the incision open a long time. So the cutting time, as we call it, is about an hour.
So now let's talk about, I know a lot of families and patients are like concerned about medications. So let's talk about, like, if you don't mind, some of the medications that generally most orthopedic surgeons use, like for a joint replacement, either in the surgery, post-op. What are some common medications that?
There can easily be 10 to 15 different types of medicines, which sounds like a lot, and it is. But each one has a specific purpose. Typically now we are using what's called a multimodal pain regimen, which means we're attacking pain every way you can feel it. And pain is the thing people are usually most worried about when it comes to surgery. They're also worried about narcotics. Everyone knows about the opioid epidemic. And I mean, things have changed even since I was a resident. We used to just give people 95 narcotic pills because that was the most we could prescribe, and we didn't want them to have to bother us with refills. Now we give them about 20 or 30 because they probably won't need much more than that, which is shocking. There are narcotics, which everyone knows about, and we typically give 2 different types, a weak one and a strong one, and say, take it if you need it. And most of the time we're not even refilling the strong one, or people don't take many at all. Tylenol is very important. And many people think, well, Tylenol doesn't work for me. Well, it may not in isolation, but combined with everything else, it will be helpful. And the doses we're giving are much bigger than people are used to. Anti-inflammatory medicines, both NSAIDs and steroids, have a very important part to play in surgical recovery. There are medicines that interfere with clotting in good and bad ways, and one that we use can actually help with stiffness and keeps people from bleeding, which is important. That's actually how we have been able to decrease the amount of blood transfusions. It's extremely rare for someone to have a blood transfusion after surgery. A lot of my Jehovah's Witness patients ask about this all the time, and it's very, very rare. In fact, I don't think I've ever given someone a blood transfusion from just a primary surgery. Which means just a simple joint replacement. It's never happened. Now, there are also blood thinners we give because you don't want a blood clot after surgery. The other thing you don't want is an infection, so we give antibiotics too. You can have muscle spasms, so we give muscle relaxants. Surgery is stressful, your stomach can hurt, we give you an antacid. You can get constipated, so we give you something just in case. You could be nauseated, so we give medicine for that. You don't have to take
all the areas, basically. You're hitting all the areas to prepare and make sure.
But these are all things that can happen. These are all things that you might get. And then there's anesthesia. All that too.
You're gone after that. That's crazy.
But even then, we use numbing medicines in the operating room of several different types.
Walk us through that.
Most knee surgeries are a little different than hip surgeries. For knees, there are several different, what's called a block, where they can target specific nerves that go to the back or the front of the knee. And the anesthesiologist will do that. I also do that during surgery. I fill the joint with numbing medicine, which is helpful. And during the surgery, people will typically get a spinal, which means that they are numb from the waist down only for an hour or two, which is about what you need for the surgery, which decreases their pain and inflammation and everything else. Now, for a hip, there are several different nerves that you can somewhat target, but you do have to be able to walk eventually, and so we'll use a spinal for the surgery, but after that, the numbing medicine we leave in the OR helps for typically several days.
So I know people sometimes get scared of the word spinal, like a spinal block. What are some things that you say to families to say, hey, like, to kind of ease their fear when it comes to like being not able to like walk or something?
It's usually mostly the men who are scared of it. Because the ladies say, oh, it's just like a baby. And you say it's actually not even that bad because they left it in for a while. This is just a one-shot spinal. It's quick and easy, and then it doesn't last very long, which is good because people are up and walking, like going home the same day.
Wow, so it's really just kind of easing them, helping them understand what the purpose of it is.
Right.
That's cool. Wow, that's awesome.
And some patients, they have to be awake during surgery because their heart can't handle it, and a spinal is very often the safest way. Many patients say, that is really creepy, I don't want that, knock me out. And I said, that's fine.
I'm done.
we'll do it, you know.
Wow.
But there's all sorts of ways to get things done, just depending on what the patient needs.
That's cool.
Now, some of the patients that have had to be awake for surgery, I do make them pick the radio station.
Oh,
you know,
nice.
and they don't have to sing along, but
Yeah.
every once in a while, if the medicine's right, they will.
That's cool. That's very cool.
We've had people request, Broadway show tunes or,
Disney.
classic rock, all sorts of things.
That's cool. That's cool.
All right, if you're watching this, thank you so much. If you haven't already, please like and subscribe this video. Let's keep it moving.
Now let's kind of walk through the actual surgery. Yeah, and so we were talking beforehand, we could probably have a video that we would like to have you kind of walk through and just kind of guide families through what it is that you're doing. So let's take a look at this video here real quick.
This is the video that scares everybody.
I know, yeah.
Because in that picture, they just took a huge chunk out of the knee.
Go ahead.
All right, so starting off normally, you open up the incision, and you need to actually be able to see to put the pieces in. So they flip the patella up on the side, and usually you replace that. And here, they take a huge chunk of bone out on both the femur and the tibia. That's not really how we do that. I typically tell patients, this is how we used to do it, or you can do it like this. Sometimes I do that in Europe, but here in the United States, that's not how we do it.
So this is like you said, this one really scares
This is the
people.
one that scares people because they think that, well, you have to amputate my leg in the middle of surgery, and that's not quite true. What we're doing here, typically, when I'm doing this surgery, when a modern surgeon does this, you're taking small slivers of bone, about 8 millimeters or less. Here, they just cut off the bottom half of the femur there. You can do that, it just doesn't feel natural. So see that huge gap?
Yeah.
That's what people are worried about. Now, this part is right, where you put something into the tibia, and then you put something on the femur. This is a little different design-wise. But then it moves back and forth. And there's a metal piece that goes in. That's the part that's coming in. That's the patella. Of course, your tendons are normally attached to it. There they go. They came back.
Gotcha.
And then you put it all back together. It's that easy,
It's that easy, man. Because a lot of families are like literally they just go and they go.
Yes, I know.
Knee replacement.
My dad has knee replaced a year ago. He was sending me videos every day. If it's like this, I'd be like, Dad, no.
And then it causes fear. Like, and they're like, oh my gosh, what am I going to do?
Oh, yeah. Well, I mean, now seeing that, I can see why. This is showing the knee with arthritis. The models always have it as red, and it's kind of pink when it gets down to bone. Now, this part right here is showing you when all the pieces are in, what does it actually look like? Of course, none of your muscles and tendons are in this picture. We like to leave all of those as much as we can. There are some that are either worn out from arthritis or we have to take out to put some of the pieces in. But typically, all of your tendons we keep there. Usually the ACL has to be sacrificed or is already gone. But the PCL, the way I do it is we like to keep it as much as we can. Your MCL, your LCL, we keep those pieces unless they're worn out, and then we compensate for it.
Oh, sweet.
So that's the patella up front, you got your femur up top, tibia on the bottom. Typical incision, you're making it over the front of the knee, and then you kind of spread the skin out underneath, and then you get into the joint itself. You flip over the kneecap like that. Most of the time we'll replace that, especially if there's damage. And then you make cuts that look just like this. So a flat cut on the tibia, the bottom bone, a flat cut across the patella, and you'll replace that with what's called a button. And then on the femur, you make several different angled cuts where you're just taking a few millimeters of bone off so that you can basically put an end cap on either one of them. But you can see that the ligaments are still there. They're still in place, and we depend on those for the knee to function properly. So then, this is what the pieces look like once you put it in. And there are many different brands, but they all are pretty similar in how they're designed. And that's kind of what it looks like inside the bone. You have to anchor it inside the bone in some way, either with a little peg or a bigger peg or cement. Sometimes you can actually make it so that the bone grows into it, but they have to stick to the bone somehow. And so that's how it moves. It glides nice and smoothly, and we try and keep the basic mechanics of the knee once we replace it and put it together.
That's awesome. So that cement, I'm just curious now, you mentioned the cement that's going in there.
Mm-hmm.
Right in there, what does that entail? Like, is it something that, like, it grows into the bone, or how does that work? Just curious.
There are basically two main ways to get something to stick to bone. The most common way is to cement it in place, which is I describe as glue. Grout is probably more accurate, but it bonds both to the implant, and bones are very porous, and so if you take it and pressurize it, it will get into the bone, and then it kind of unitizes it together. That's how we've done it for a long time in both hips and knees. Now we are switching over, especially in the hips in the United States. Most of the time we're not using cement at all. We're starting to do that in the knee as well. The reason for that is theoretically, if the bone grows into the metal, into the implant, it might be able to last you the rest of your life, which is ideal, and especially as our patients are getting younger. That's the way we want to go.
Right. Wow.
So here's our model, and this is what the muscles look like underneath. And you can see there's a lot of muscles and there's a lot of planes. There's a lot of ways to get to the hip. The way that I do it and the way that a lot of more modern surgeons are doing this is going from the front. What that does is it takes advantage of a plane in between muscles instead of cutting them off. So that's what your skeleton looks like. That's where you're ultimately trying to get, is to the ball and socket hip joint. There's a lot of complex anatomy around there. There's the acetabulum, which is the socket, the femoral head, which is the ball, and the femur, which is the rest of your leg, obviously. But you have to make sure that you're explaining those terms to patients as you're going through it.
Or they'll say, bless you.
Yeah, exactly. So that you can see that's how it moves, but as you get arthritis, the ball isn't round, the socket isn't spherical. Pieces of them can break away, or you can get bone spurs that will interfere with motion. The hip gets stiff, and sometimes, depending on the condition, it can even collapse. So that's kind of what you're dealing with. That's what you're trying to fix. So then you have to make an incision on the skin, and this is showing you those muscle planes and the way that they're going to get to it. Typically, even an anterior approach, you'll still have the incision sort of on the front, but sort of on the side, versus in the back, which is what most people are used to. Those are the muscles you want to leave intact, the rotator muscles of the hip. And then as your hamstrings, you should hopefully never see those, but you have to make sure that they're intact as you're going through and doing the approach. And these are the rotator muscles. If you're going from the back, you cut those off. These are your adductor muscles. These are the ones that bring your hip across your body. Those you should be able to keep alone in most approaches. And this is your rectus muscle. This is a hip flexor and also helps extend your knee. This one you will see, so you have to be careful with it. So kind of on the front, kind of on the side. You enter in through, you get between these two layers of muscles, and then you can see the hip. That's what it looks like when you're all said and done, where you have the brand new stem, the ball, the socket, and the liner in the socket. When you're all finished, it looks pretty much like that. And it actually can be pink, believe it or not.
Really?
Yeah, we typically are using a ball that's made out of ceramic, and so you take the old ball off, and you actually don't need it anymore. After that, you could use it for some spare bone if you needed. Then you prepare the socket, where you put in a metal socket with a liner. Then you put a stem inside the femur with a new ball on top. And there are varying sizes of all these, and so you can customize to the patient exactly what they need. And in this model in particular, they've made it such that it's what we call press fit, so the bone should grow into these implants.
Like
Exactly. it does make that noise.
Does it really?
Yeah, if you do it right.
Oh, this works.
What's nice about doing these from the front is patients tend to bounce back a little quicker. A hip surgery, a replacement is a great surgery. I'm not sure if you're familiar with the Lancet journal, but it's one of the big scientific journals, kind of like New England Journal of Medicine that people just heard of. They said that the hip replacement surgery is the surgery of the century because of how much it has brought people's quality of life
That's pretty
back.
cool.
Yeah. It doesn't matter if you do it from the front, the back, the side, at a year,
Still gonna
everybody's
help.
doing better. Yeah.
Precautions. So anterior approach, are there precautions post-op?
We have looked into this. If you give your patients precautions or not, there's no difference in dislocation. It doesn't really seem to do anything from the front. Often in the back too. Really, I just tell people, don't be crazy. keep your hip close to you.
Yeah.
Don't cross your legs like I'm doing right now. But really just think about your movements. Don't do anything extreme, and don't bend over too far, and it should be fine. We are twisting your leg and moving it in all sorts of different planes during surgery. We try and simulate most things people would do. Typically, as long as you don't fall, you should be okay.
Okay, so now like we've got through the surgery, and surgery's done, and now they're going into their room in the hospital. What is life after that? What is the next steps for them to recover, to get back to like what they enjoy to do, which is like golf or hanging out with the grandkids.
Oh yeah. So you're done with surgery. What happens next? That is very different now than it was even 3 or 4 years ago.
Yeah.
Now most patients are going home the same day of surgery, which terrifies a lot of people. Which that makes sense. This is major surgery, and we're just sending people home. Well, we found that it's very safe to do that. Patients actually tend to really like it. One,
no hospital food.
Exactly. You have your own food, and the nurses do a great job, but they can't get to you immediately. If you need a pain pill at home, it's right there. You have your own bed. People aren't checking your vital signs 10 times a night. Now, there are certainly patients that need to be at the hospital. So if they need to be there, they get to stay there, and we keep an eye on them. Therapy works with them. But if you go home, therapy comes to the house. They come and they check on you. You're not exposed to the viruses and colds and flus that are at the hospital. All the hospital transmitted diseases you don't get exposed to. But you start working right away. You start working with therapy, the exercises that we give patients, and we want you to get your motion back and be as normal as you're allowed to be pretty quickly. All in all, joint replacement recovery, there's certain parts of it that take a year. We're on your body's timeline for certain things. Swelling takes a while. It takes months to build muscle. That doesn't happen overnight. But functional recovery is very quick. We tell patients you're 89% done 2 or 3 months after surgery. If you're working from home, people can often get back on the computer 2 to 4 weeks after surgery. If you're a manual laborer, it's probably going to be 6 to 8 weeks before you're ready to go back, because we don't want you to go back too soon and hurt yourself.
Really
but if you're doing computer work, I mean, basically, if you're not taking narcotics, you can work. You definitely can't work while you're on that. But I want your joint to be the priority in recovery. So I'm happy to write patients for whatever time off they need, as long as they can do the work they need to participate with therapy.
So you reminded me of something. So my son's teacher calls kids, like, if they're doing really well, like a rock star, right? Or they're doing pretty well, they're going to be a rock star, right? Encouraging. What are some patients that you've seen that are like rock stars in terms of like they do really well post-op, and then why? What would you think?
We were actually talking about this today in
the
operating room. And we kind of said that on average, it seems like women recover a little better than men.
Man, we're just not doing well in life right now, right?
But the rock stars are typically the guys, like the people that just bounce back. You're like, that's unbelievable. It's very often like the old ranchers. Oh my goodness, they just bounce back. But sometimes you worry about the rock stars a little bit, because they will push it too far. Like,
that's true.
When you get the picture 7 days after surgery.
Can I do this?
No. When you get the picture of someone who has just killed a deer, with their surgical bandage still intact, you're like, well, you should not be doing that.
Or
how far are you hauling that thing? Or when people go out golfing 10 days later, you're like, what are you doing? Calm down. You're going to get yourself in trouble.
That's true. So kind of,
you almost don't want to advertise the rock stars, because you don't want people to do that all the time. But I mean, we have patients that go back to skiing, ice skating, taekwondo, all those kind of things.
That's cool.
And really, a lot of people can do that. Your pre-surgery functional level very often predicts how well you will do.
And that becomes your next new baseline, kind of. That's cool. That's awesome. So now, just as we kind of come to a close, like what would you recommend? So I read a statistic, there's like 1 million people a year that are getting joint replacements.
That sounds about right.
And so like, if that's the case, then someone we know is going to get a joint replacement. What would you recommend to someone if they're in a lot of pain, and that they need, or like, say for instance, their aunt and uncle, that they need, so they're just not listening. What would you recommend to kind of help them understand and ease their frustrations, or even just ease their angst, you know, about that.
One thing I try and communicate to patients and families is that there's hope. You know, if you're ready for surgery, that's very often hopeful, and people will say they're surprised to be excited for surgery. And if you're scared of surgery and you're not ready for that yet, there's still hope there too. There's almost always something we can do. Don't be afraid of the unknown, because there are lots of doctors out there that want to get you better, want to talk you and walk you through the process. Don't be fearful. Do your homework. Find a surgeon that cares about you, and if you don't jive with that person, that's okay. Like, people have different personalities. Sometimes you get along with your therapist, sometimes you don't. And you need to make sure that the people that are taking care of you are invested in you too.
That's a good point, because you mentioned that. Like, I think a lot of times patients may feel afraid of, like, if you don't feel comfortable with that one doctor, that it's like taboo not to go find another doctor. Like you said, I mean, like, you have to be comfortable with that doctor. That's really good.
Right. And, you know, some of us doctors don't have the best personality. We're stressed. Sometimes we don't spend as much time as we'd want to with people. But if you feel like you're not being heard, that's important.
That's true. Man, that's really good.
And I think people will recover better if they feel that way too.
Yeah, that's good. Man, that's awesome. Man, Dr. Wright, thanks for hopping on. That was good. This is good.
It's great.
This is really great.
Love going through these things.
This is awesome. Yeah. So if you ever have any questions, please feel free to reach out to Dr. Wright as well. He's available. But it's my good friend, so we're always going to do this a lot. So, but yeah, see you guys next time.